Well, now we'll begin our second session after the break, and I'll invite Dr. Keith Strauss from Cincinnati Children's Hospital to come and speak to us about current CT dose metrics, making CTDI size specific. Thank you.
Can you hear me in the back okay? That's interesting. No indication from the back that they're even connected. Okay. So my challenge this morning is to talk a little bit to you about standard CT dose metrics. I want to acknowledge my co-conspirators that were involved in developing the size-specific dose concept, TG204, and also Don Fry, who provided a few slides that I adapted. So we're going to talk about CT dose indices, CTDI 100, vol, W. We'll talk a little bit about the difference between displayed and measured CTDI vol and DLP, which leads us to a clinical dilemma, and that's really the reason the AAPM developed the concept of SSDE, or size-specific dose estimate. I'll talk a little bit about effective dose limitations with respect to CT dosimetry, and look at a simple application of SSDE in the clinic, and wrap up by talking a little bit about estimating organ doses from SSDE. So in the real world, along the z-axis of the patient, we have a distribution with dose tails because of scatter radiation. We have a rounded off peak dose that we need to deal with. And so this profile, if you will, radiation dose profile, is usually characterized by the full width at half maximum, and that's equal to NT, which Mike McNitt-Gray did a nice job of defining this morning and called it nominal collimation. And so really when we talk about measuring an integral, that's just a mathematical term for meaning we're going to measure the area of this distribution when we measure the CTDI. So CTDI represents the average integrated absorbed dose along the z-axis from a series of irradiations. And of course we have individual pulses here that were acquired axially, and we have the peak dose from each slice, but we see that the tails, due to scatter, also contribute to dose above each one of those peak slices. So in reality, the total dose is elevated because of all that summing. And CTDI 100 represents the average dose of that elevated dose across the scan. How do we measure this? Well, we simply take CTDI phantoms, which have a center hole and a peripheral hole. They're defined as 16 and 32 centimeters in diameter. We take a pencil ionization chamber and we place it in the central hole of the phantom, and we put a plug in the periphery, and we make a measurement, and then we reverse things and we put the ionization chamber out at the periphery of the surface of the phantom and make a second measurement. These are just some images provided by John Boone that show the 32 centimeter phantom on the left and the 16 centimeter on the right inside the bore of a CT scanner. When we make these measurements, the surface dose is always, for the 32 centimeters phantom, is approximately twice the dose of the central measurement. And so in relative units, if we have 100 units at the surface, we're going to have 50 at the center. For the 32 centimeter phantom, for the 16 centimeter phantom, if we have 100 relative units at the surface, we're going to have 90 units at the center. So we have much more attenuation of the radiation coming into the patient when we have a larger patient, and as a result of that, our central dose is significantly less for a larger patient than it is for a smaller patient. So basically, what is CTDIW? Well, it's a weighted CTDI, and the idea behind it is we're trying to measure an average dose for the radial dose distribution shown here in the phantom. As we move out from the center, my dose is going to increase radially. And so the weighting factor is simply defined as we take a third of the central dose and we add 2/3 of the surface dose, And if we do the math here, we get 83 milligray, assuming, again, that we have the numbers that I'm showing. And that's for the 32 centimeter phantom, and it's really an average dose over the X and Y direction. So we really do need to remember that when we talk about CTDIW, we're talking about one single average dose that we're trying to characterize the dose distribution with over the XY direction of the patient. So let's do a little experiment. Let's actually measure a CTDI vol. And CTDI vol is simply equal to CTDIW divided by the pitch. We needed to develop the CTDI vol term when helical scanning came into vogue. And so what I did in this experiment is I used identical scan parameters for 3 different measurements. I used the same KV, tube current, rotation time, made sure I was using the same bow tie filter, which is not what you would necessarily do clinically. As you're doing small patients, as you pick the field of view of the scanner, depending upon the design of the scanner. And I used the 3 different phantoms. Now, because I used the same parameters for all 3 measurements, my machine is actually producing the same amount of radiation for all 3. But here's the results of the measurements. And if I calculate CTDI vol, I get 47 milligray for the smallest phantom, and I get 18 milligray for the largest phantom. And what we notice here is that the measured CTDI vol increases 2.6 times as the phantom size decreases. And again, remember that my scanner output in these 3 measurements is identical. But we do have a difference in dose to the phantoms. So that's a measured CTDI vol, which should not be confused with a displayed CTDI vol on the scanner, because the displayed CTDI vol represents the distribution of dose given to that cross-sectional area for one of 2 defined phantoms, either a 16 or the 32 centimeter diameter phantom. And so it's a powerful tool. It reflects changes in, again, my radiographic parameters of my CT scanner, and in addition to that, the bow tie filter, and what's sometimes forgotten by some people, the distance from the detector of the scanner to the focal spot of the scanner, because the inverse square law is going to change the amount of radiation that reaches the patient in the center of the gantry. So the displayed CTDI vol was originally defined to simply be a method to compare the output of 2 different scanners to a fixed defined phantom. And CTDI vol does a wonderful job of that. It's a semi-reasonable index of the dose associated with CT scanners if we use a very small fan beam width, less than a centimeter. We still underestimate, however, the dose with the CTDI, even at less than 1 centimeter. And as we get out to 40 centimeters 40 millimeters and larger, we certainly do not capture all those tails, and the physicists in the room are all aware of the fact that that's what TG 111 really addressed, that was published by the AAPM recently. But if you don't take anything other from this lecture that I give this morning, please keep in mind that the displayed CTDI vol does not represent patient dose, because there is no compensation in that number whatsoever for the size of the patient. So let's go back to that experiment. What's the displayed CTDI vol values going to be? Well, if the scanner is displaying the CTDI vol based on the 16 centimeter phantom, for all 3 sizes of patients that are represented here, we're going to get 37 milligray. Because CTDI vol is defined to a phantom size, not a patient size. And if we use the 32 centimeter phantom, we're going to get 18 milligray. So what does that mean practically in the clinic? If I take my CTDI vol for these 2 patients, one obviously is a child and the other one is an adult, I'm going to get the same CTDI vol displayed on the scanner, provided I use the same scan parameters for each patient. And I'm going to get 18 milligray in my previous example. So we've got a clinical dilemma. If the scanner used the 16 centimeter phantom, my adult dose is going to be overestimated while my pediatric dose is going to be underestimated by the CTD eyeball. If the scanner used the 32 centimeter CTDI phantom, both the adult and the pediatric dose will be underestimated. And for the smallest pediatric patients, that underestimation is going to be by a factor of 2.5. So it's a considerable significant error. And of course, if we take the CTD eyeball and the DLP from the DICOM structured reports and put it in the patient's medical record, what we're doing is we're simply transferring these systematic errors, and we're really not representing patient dose. In defense of the people that developed CTDI vol, they never intended the CTDI phantom, which is shown here on the left, to be a clinical model of the patient. We have anthropomorphic phantoms today, as shown on the right in this slide. On the right, we have an adult-sized thorax, and in the center, we have a newborn thorax, and they're better representations of the patient than certainly CTDI, but even these anthropomorphic phantoms aren't as good as the real thing. What's DLP? Well, DLP is the dose length product, simply equal to the CTDI vol times the scan length. The scan length, of course, is going to be the length of the phantom or the length of the patient that's irradiated during the scan. DLP, in one sense, represents the energy that's transferred to the patient. But just like CTDI vol, DLP is not a patient dose index because it starts with CTDI vol, which is not a patient dose index. Now, we could, if we chose, we could take the SSDE value, which is a better representation of the patient dose, and substitute that for CTDI vol, multiply it times the scan length, come up with some kind of new crazy name like SSDELP, okay? And that, indeed, is a better estimate of the total energy that's transferred to the patient than the standard DLP. And that is something that we could and would be reasonable to do. Well, DLP was developed in part to help people understand risk associated with CT. If I give a patient 10 slices of dose that are contiguous, and each one is 20 milligray in dose, I'm going to have a DLP of 200 milligray centimeters. If I double the number of slices to 20, my CTDI vol is still 20 milligray. But I think we can, even all of us in this room can agree that there's probably a greater risk from 20 slices than 10 slices, and the DLP correctly reflects that, and it has a value that's twice as great as when we were using only 10 slices. So the DLP does represent the greater biological risk. Okay, so what about SSDE? It's the size-specific dose in pediatric and adult body CT examinations. It was developed by the AAPM, and also the folks from ICRU and Image Gently were involved as advisors. The report is not a be-end and end-all to all things. It does not address correction factors for heads. It does not define those. It does not address the small, less than 1% dose that's associated with projection scans that Mike talked about earlier. It doesn't correct for the variation in differences in attenuation between the thorax and the abdomen because of the presence of air and lung tissue in the thorax and soft tissue in the abdomen. And it doesn't correct for small variations in pre- and post-contrast scans. Okay? So what is it? Well, it's simply an estimate of patient dose within the entire scan volume of the patient. It adjusts for patient size and varying attenuation from overlying tissue thicknesses. But we must keep in mind that what it does is it uses one single average CTDI value as a basis for starting the calculation. And Mike Gray showed you this morning that if we use automatic exposure control, our tube current varies dramatically, and as a result of that, we have one single CTDI vol average number at the end of the scan. So if we are doing a thorax and an abdomen, Obviously, that CTDI average value is going to overestimate the radiation production that was used in the lung fields, and it's going to underestimate the radiation production that was used in the abdomen. And so that's just another source of error, and why we need to keep in mind that SSDE is a dose estimate. It's not the patient dose. And obviously the CTDI average value is going to, as we said, vary along the z-axis. It's going to vary as the beam rotates, and it's going to vary based upon which bow tie filter you're using on the scanner. So how was SSDE developed? Well, there were 4 different groups across the country using various different phantoms and Monte Carlo computer modeling projects, and we took all the data and we put it all together, and we're kind of shocked to see as good a correlation as we got. We see an R-squared value of 0.94, and we have a plot here of effective diameter versus normalized dose coefficient. Well, the normalized dose coefficient is simply going to become the conversion factor that we use that's in the tables within the report. And this is for a 32 centimeter phantom at 120 kV. And we notice that for the smallest patients, we have correction factors of around 2.6. We saw that number previously when I did my experiment with the 3 different phantoms. We've got a number of approximately 1 for the smallest patients. If we do the conversion factors for the 16 centimeter phantom, as we would expect, at 16 centimeters, approximately, our correction factor is 1. Our factor is not as great for the smallest patients, and now we have a correction factor less than 1 for the largest adults. And again, this is for 120 kV also. So you say to me, well, that's great, Keith, but we use 80 kV and 100 kV and 140 kV. Well, here what was done was we're showing the 120 kV data curve here, and here's the curve that represents the 140, 100, and 80 kV data. And once we get beyond a 1-year-old, we have less than a 5% difference in all cases. We have a percent difference that's only about 3%. So the good news is that these conversion factors can be used for all KVs. What about the thorax? And again, there are going to be some differences. Huda published some data, and essentially there's a 16% difference at the smaller patients, but once we get to 17 centimeters, the difference is only about 7%, and greater than 17 centimeters, the difference is less than 3%. So again, we're not proclaiming that the SSDE is the exact patient dose. It's an estimate of that. And so this seems to be a reasonable way to approach that. What's the effective diameter that occurred in those plots? Well, the effective diameter is just a circle that's got the same area as the patient's cross-sectional area that we can calculate if we know both the AP and the lateral dimension of the patient. Is it okay to use age to characterize patient size? And the bottom line to that is no. This is some data that was published in 2010 for AP abdomens for newborns on up to 20-year-olds. I can draw a straight line here which represents patients of the same size, and we see that the largest 3-year-olds are the same size as the smallest teenagers. And that doesn't sit well with our intuition, but that's what the data shows us. So patient age alone is not a good indication of patient size, and we encourage people to somehow quantify the patient thickness, the path length of the x-rays through the patient during the scan. However, there is data in the report that if you don't have the patient size and you only have the age, you can come up with an average effective diameter, and from that effective diameter, you can come up with a conversion factor to come up with the SSDE. Well, how do you determine patient size? Well, you can use mechanical calipers prior to the scan. Once you have the projection scan, you can electronically measure the lateral or the AP dimension of the patient prior to doing the scan, and that's important. After this, and one thing you need to worry about, and somebody mentioned this already this morning, you need to keep the patient centered in the gantry to make sure you don't have any magnification errors if you're going to make measurements off the projection scan. Once you've done the scan, you can measure either the AP or the lateral dimension from the axial scan view. You need to know which phantom the CT manufacturer used to calculate and display the CTD eyeball. If you pick the wrong one, you've got a systematic error of 100%. Unfortunately, there's no standard out there for the manufacturers, and so we strongly encourage you to make no assumptions. Talk to your manufacturer of your scanner to find out whether they use the 32 or the 16 centimeter phantom to represent CTD eyeballs for body scans. We believe the accuracy of SSDE is about 20%. Again, I can't stress enough that this is nothing more than an estimate. And because it's an estimate, if you're going to use it, let's be logical about it and use a reasonable number of significant figures. We're suggesting that if the SSDE is greater than 5 milligray, you use only integers to report out the dose. And if it's less than 5 milligray, 1 decimal point is probably appropriate. So how does the sample calculation go? Well, here my scan is finished. I know both my AP and my lateral dimension from the axial scan. I sum them and get 22.2 centimeters. My scanner used the 32 centimeter CTDI phantom to calculate CTD eyeball, and it told me that the CTD eyeball was 5.4 milligray. I go to the right table in the report, and you notice here I'm using the table that sums the lateral and the AP dimension. I go down to 22 centimeters, which is the sum of the AP and the lateral, and I get a correction factor of 2.5. And in this case, we see that my SSDE is 2.5 times greater than the CTD eyeball. It's about 13 milligray. Now, I made the comment with DLP that I can substitute SSDE for CTD eyeball to come up with an SSDE LP. Do not, in any situation, substitute SSDE for CTD eyeball with the K factors that you may be used to using for estimating effective dose. Because essentially the K factor is a bridge that takes you from simulated organ doses in phantoms back and forth to the CTD eyeball. And of course, that simulated phantom and organ dose didn't change just because we figured out a better way to estimate patient dose. So these K factors are not appropriately used with SSDE values. So while I'm on the topic of effective dose, let's talk a little bit about some of its limitations that are sometimes overlooked. Can effective dose be used to estimate an individual patient's radiation dose or organ doses? And the answer is no. It's not its intent, despite the fact that you can find many publications that have done it. Well, what is effective dose originally for? It was really defined for radiation protection concerns of occupationally exposed workers. It had nothing to do with patients. However, effective dose can be used to do comparisons of the biological risk between diagnostic exams of different types. But notice, in nowhere here are we talking about individual patient doses. We're talking about patient doses to groups of patients potentially, but not individual patients. And then this is just a reference list that's in your handout if you'd like to read and really learn more about some of the limitations of effective dose. So here's a simple application of SSDE. Let's assume I'm in a pediatric institution and I want to set up some reference values for doses for various size patients, and I don't really realize that CTD eyeball is not a patient dose. And I make the assumption, well, I want 8 milligray, 12 milligray, and 16 milligray respectively for my newborn, my small adult, and my large adult. And when I'm talking about large adult here, I'm talking about someone that's maybe 250 pounds or bigger, because just as we had large errors in patient doses for the smallest patients, we've got large errors in patient doses for the largest patients. We are not delivering as much dose to the largest patients as we probably think we are, because we've never done the calculations. And again, the overlying tissues shield the inner tissues on the very large patients. So anyway, if I do this might be a reasonable choice for me to make based upon CTDI vol. Well, what's the SSDE based on the 16 centimeter CTDI phantom? It's 9, 10, and 7 milligray, which doesn't make really any logical sense. And if I do it based on 32 centimeter CTDI, it's 19, 20, and 15. And if I've got a CT scanner that switches between phantoms as the patient gets larger, I might have 9 and 10, or the 16 CTDI numbers for my small adult and my newborn, and I'd have for the large adult, I'd be using the 32 centimeter CTDI phantom, and those numbers just don't make any sense, and I don't think we're doing any service to any of our clinical colleagues by expecting them to believe these kind of numbers. So maybe a better choice is, let's pick some reference doses based upon actual patient, well, not actual, but estimated patient doses. 9, 12, and 15 milligray might be reasonable reference doses for the abdomen of patients. And now if I go back and look at the CTDI based upon the 16 centimeter phantom, I have 8, 15, and 35. If I look at the 32 centimeter phantom, I've got 4, 7, and 16. And if I have, again, a combination, it, again, doesn't make a lot of sense of 8, 15, and 16. And back here at the 16 centimeter CTDI phantom, I could maybe see some pushback from a clinical person saying, I don't want to give 35 milligray of dose to a patient from an abdomen, and none of us do. Obviously, it's really 15 milligray, not 35. Okay, and finally, SSDE can be used to do some first approximation of some organ doses. Now, please note, I said first approximation, rough. That means rough and not very precise. Certainly we can use it for soft tissues only, and the organ's got to be completely in the scan volume. I'm never going to be able to estimate the organ dose to the bone marrow of the patient from a CT scan, because I'm never going to do a whole body CT scan. Remember, we've got this radial dose distribution, and that radial dose distribution is more pronounced for adults than it is for kids. All right? So it's less of an issue for kids, but let's assume that's my organ. It's relatively large, and the 83 milligray average that I came up with initially when I did the CTDIW is probably not a horrible estimate of the average dose to that large organ that encompasses both inner radii and outer radii. However, for that small organ near the center of the patient, if I use the SSDE to estimate the organ dose, my SSDE is going to overestimate the organ dose because it's close, that small organ is close to the center of the large phantom. So in conclusion, estimating and managing patients' CT doses obviously are important to all of us, and SSDE can help with all of these tasks. Thank you.
Any questions? Any questions?
Keith, you pointed out that the CTDI vol is the average over the length of the scanned patient, and that diameter is crucial to the SSDE. Where do you choose to define the diameter of that patient, which is not a cylinder?
That's a great question, and I think in some ways it's got a practical answer. Let's assume I do a thorax, abdomen, and pelvic scan on a patient. Okay? Probably the smallest dimension of the patient is going to be the abdomen. Okay? If I pick the abdomen for the diameter, what am I doing with my dose? I'm going to overestimate it. If I pick the pelvis, what am I doing? I'm picking the largest body part. I'm going to underestimate the actual patient dose. So I think it's a good practical question. If you pick the smallest body part, you're going to overestimate the overall average patient dose. If you pick the largest body part, you're going to underestimate it. So probably the better thing to do is make a measurement at the largest portion and then at the smallest portion, take the average or some weighted average of that depending upon how much time you're spending scanning those various body parts.
The automated dose measuring systems do this in some automated manner, which I'm not aware of. Any idea how these radiometrics or those parts? I know Radiometrics is calculating SSDE, but I do not know what they're doing to compensate for that. Do you know?
No, they have not told us what the accuracy is of that, but I'm pretty sure that they run into the same issue that the SSDE runs into, which is if you have a combined body part like chest and abdomen, it's going to average out and underestimate or overestimate for some regions. I have one question for you, Dr. Strauss, if you don't mind. My question is that you mentioned that age can be used to calculate roughly the SSDE conversion factors. Have you looked at the weight instead of the age? And is that better than using just the age?
The question is, can you use weight instead of age to estimate patient size? And obviously you can use weight. It's best if you use weight and height. I mean, obviously I can have a very tall person that's going to be heavier than a short person, and they could have the same effective size. Okay? The problem with weight is you don't necessarily know weight at the time you do the scan. You probably know the patient age, and you obviously have the patient available to you, and you can quickly measure their thickness. But you may not have a scales available to you to measure the weight, and I don't know of any department that goes to the trouble of measuring patient height. So